Good morning. I guess good morning for the West Coast. Happy almost noon for the East Coast. My name is Carr, and this is Taking a Deep Cleansing Breath, Updates and Management of Chronic Rhinosinusitis with Nasal Polyps. My name is Carr. I'm an Associate Professor of Medicine at the University of Arizona. My disclosures are shown on this slide. Our learning objectives today are 1, to analyze the phenotypes and endotypes of chronic rhinosinusitis with and without nasal polyps, based on what is understood thus far about immunologic pathophysiology and its impact on disease burden. We'll summarize the mechanisms of action of new and emerging targeted biologics for CRS with nasal polyps, as well as the efficacy and safety profiles revealed in the clinical trials for those drugs. And finally, we'll implement a shared decision-making with CRS with nasal polyp patients to determine when a biologic, surgical, or other treatment is appropriate for that patient. We're going to jump in this morning with some pre-test polling. So we'll ask a few questions here, and we'll ask that you click on your answer and then hit the submit button so that it's captured. So first question, the primary cytokines involved in type 2 inflammation, the most common endotype in patients with CRS with nasal polyps, are, is it interferon gamma and IL-12, TNF-alpha IL-6, IL-4, IL-13, and IL-5, or IL-17 and IL-2? Go ahead and select your favorite choice here. And in a couple of seconds, we're going to move on to the next question, and we'll answer these again at the end. Which biologic showed improvement in nasal polyp score by greater than 2 points in close to half the patient population at weeks 24 and 52? Benralizumab, dupilumab, mepolizumab, or omalizumab? Okay, and we can move on to the next one. Which is the most commonly observed treatment-emergent adverse event across the clinical trials of all biologics studied for nasal polyps? Epistaxis, injection site reactions, nasopharyngitis, or abdominal pain? Okay, great. And the next question. Mr. Brown, a 42-year-old male patient with severe CRS with nasal polyps, returns 12 months after endoscopic surgery complaining of persistent symptoms. You suspect nasal polyps have regrown, as type 2 inflammation is a predictor of polyp return in greater than 50% of cases. Disease scoring systems show some improvement, but do not meet euphoria criteria for adequate response. What does euphoria recommend now? Return to medical management and oral corticosteroids, biologic drug or revision surgery, exhalation delivery system with fluticasone, or corticosteroid-eluting implantable stent. Okay, great. And then moving on. Last question. Feeling discouraged, Mr. Brown says if the nasal polyps are just going to grow back anyway, he doesn't want to go through all the expense, pain, and downtime of undergoing surgery again. Shared decision-making means the best action now would be to, 1, advise him to reconsider surgery because 30% of patients do require repeat surgeries, to apprise him what the guidelines recommend and ask him to decide between 2 options, to give him information about all available biologicals and ask him to choose one, or letting him know all his therapeutic options and the pros and cons of each. Wonderful. Okay, great. And that was the end of our pre-test polling. We'll get a chance to review some of these items, and hopefully we'll feel comfortable answering the questions at the end. So here's our case study to introduce this kind of idea of nasal polyposis. So Bob is our patient today. He's 45 years old, and he has CRS with nasal polyps. He also has asthma that he struggles with in addition to the nasal polyps. And he's letting you know that the polyps are worsening over the past couple of years. He's required multiple oral steroid bursts within those last 2 years to help control his symptoms. But he says he's compliant with the saline irrigation that you've previously recommended, as well as the intranasal corticosteroid sprays that you've recommended. He acknowledges that his sleep is bad, his work productivity is reduced, and his social life has been negatively affected as well. He's never had surgery. So what additional information are we going to consider at this point? And what would be most important for us to get a sense of how we can help Bob better? Are we looking at blood eosinophil count and serum IgE, so biomarkers of inflammation or type 2 inflammation? Are we getting a CT scan of his sinuses and nasal endoscopy to look for extent of disease? Are we getting a spirometry to assess his asthma? Are we doing an FeNO, which is an exhaled nitric oxide test, another marker of T2 inflammation? Maybe you would do all of the above. Let's see what's recommended. So chronic rhinosinusitis is a very common disease. There are 29 million Americans in the United States who are diagnosed with chronic sinusitis, and this represents almost 12% of our population. Among these individuals, 20% of them have the subtype CRS with nasal polyps, and this group is predominantly slightly male. The 80% of other patients with chronic sinusitis have non-nasal polypoid disease, and this group is predominantly female. Interestingly, and perhaps inexplicably, the United States has the highest rate of chronic rhinosinusitis in the world. Our 12% can be compared here with Canada at 4.6%, Brazil at 5.5%, the European continent at almost 11%, China at 8%, and Korea at 6.9%. Not well understood why this is the case, but certainly something to think about and to remember it is important as a diagnosis for our patients. In addition to disease burden, medical cost is significantly higher for patients who have nasal polyposis. Using a database, a large claims database, this observational study compared about 10,000 patients with nasal polyps to matched controls who did not have nasal polyps. And I think you can appreciate here that those nasal polyp patients incurred substantially more cost per year in medical costs than the controls, about $11,500 more. And this was split among pharmacy costs, medical costs, office costs, and other ambulatory costs. How do we diagnose chronic sinusitis, and what are the important comorbidities we need to be looking for? Chronic rhinosinusitis can be diagnosed clinically, but we also get objective criteria to support the diagnosis. So you should suspect chronic rhinosinusitis when your patients present with at least 12 weeks of symptoms that can be sort of exacerbating. They can be, kind of days that are worse, days that are better, but generally persistent symptoms for at least 12 weeks, including mucopurulent drainage that can come out the front, drain down the back, or both. It doesn't have to be discolored. It can just be clear and thick. Nasal congestion or obstruction, so that sense that the air is just not moving well through the nose. Facial pain, pressure, or fullness, which suggests that the sinuses are being involved in this process and that it's not just limited to the nose. And then finally, a decreased sense of smell, which is one of the major indicators that there may be presence of nasal polyposis as well in those patients. The objective criteria we use are endoscopy, so essentially looking into the nose in a way that's relatively comprehensive to confirm not only the presence of drainage or mucosal edema, but the presence of polyps, and if so, the size of polyps. A sinus CT scan can also be very useful to document the extent of the disease, the number of sinuses that are involved, and how severe the sinus inflammation is. So 2 clinical criteria and 1 objective criteria constitutes this diagnosis. Medical costs are one thing, but really the cost to our patients is the burden of their symptoms on their day-to-day life. And we know that the disease burden of chronic rhinosinusitis and the impact on quality of life can be close to that of decompensated heart failure. And if you can consider that, these patients really do struggle. So the pathophysiology and the impact on the Disease is a little bit different when you think about the non-polypoid disease versus patients who have nasal polyps. So on the left of this figure in the blue, you see a representation of what might happen in patients who have non-polyp disease. This is a disease that can significantly affect any of the sinus cavities and often affects many of the sinus cavities. And what we can see is thickening of the lining of the sinus cavities and sometimes filling of the sinus cavities. Often we'll see that thickening or filling can block the drainage tracts, obstruct the drainage of the sinuses. And on the right, you have the nasal polyp disease, which can affect, again, all of the sinuses. And you can have a polypoid appearance of the inflammation, as well as you see the presence of nasal polyps within the nose, so growing off of the middle turbinates or out of the ethmoid turbinates, out of the ethmoid sinuses. Patients who have non-polyp disease tend to have more facial pain and pressure, in addition as prominent over the other symptoms. And patients with nasal polyposis will report a loss of sense of smell in addition to the obstruction of breathing through the nose. On the right are some images that are taken from real-life patients that show you what nasal polyposis may look like. The CT image on the top, on the left is a control. You can see normally aerated sinuses that are nice and black, which says that there's air there. On the right, in the sinusitis with nasal polyps, you can see that there's circumferential thickening of the sinuses. It has a sort of bumpy appearance to it, and the nasal cavity is almost completely obstructed by polyp tissue. When you look into somebody's nose, on the left, on the bottom panel is the control, so kind of a normal appearing, normal color, normal size turbinate. On the right, you see that there are a couple of nasal polyps growing in that nose. The nasal polyps almost look like grapes. They're kind of clear, shiny, gray, and don't move when the patients blow their nose. There are definitions for uncontrolled chronic rhinosinusitis with nasal polyps and severe chronic rhinosinusitis with nasal polyps. So when we use those terms, we can refer back to these definitions to really understand what we mean by this. So when we use the term uncontrolled CRS with nasal polyps, these are patients who have persistent or recurrent polyps despite long-term intranasal corticosteroid use. These patients also have received at least one course of oral corticosteroids within the past 2 years and or have had a previous sinonasal surgery to treat the nasal polyps. So these are essentially patients who still have polyps and despite the use of medications and surgery. It's important to remember that long-term systemic oral corticosteroids is not recommended for patients who have nasal polyposis, although patients can have short burst courses of oral corticosteroids, such as 5 days of therapy at something like 0.5 to 1 milligram per kilogram per day. Severe chronic rhinosinusitis with nasal polyps are bilateral polyps with a nasal polyp score that's at least 4. And persistent symptoms despite the appropriate therapies of intranasal corticosteroids, and these patients need additional therapy. So the nasal polyp score is a score that we'll talk about in just a little bit that's determined by bilateral nasal endoscopy, which essentially describes how big those polyps are and how much of the nose they're occupying. The highest nasal polyp score is 8, and so if the nasal polyp score is at least 4 out of 8, then that's consistent with severe. And you can assess persistent symptoms through a variety of different mechanisms and scoring tools that can assess loss of sense of smell, nasal congestion, the sinonasal outcome test, and a visual analog scale. These definitions come from the 2021 Euphoria update. Euphoria is the European Forum for Research and Education in Allergy and Airway Diseases. And this was a group of CRS experts. Chronic rhinosinusitis with nasal polyps is frequently associated with comorbidities such as aspirin-exacerbated respiratory disease, asthma, and allergic rhinitis. Aspirin-exacerbated respiratory disease, or NSAID, a nonsteroidal anti-inflammatory drug exacerbated respiratory disease, is present in about 28% of patients who have nasal polyps. And it's really not present in patients who don't have nasal polyps because the nasal polyposis is a very important part of this disease. Asthma is present in 68% of patients who have nasal polyposis, so really showing that that whole airway is involved in this inflammation. And then about half of patients who have nasal polyposis report allergic rhinitis. You can see that there are still patients who have non-polypoid chronic sinusitis who report asthma and allergic rhinitis, so you absolutely can have comorbidities for the non-polyp disease as well. It's just not as frequent. Looking specifically at asthma as a comorbidity, we know that patients who have nasal polyps tend to have pretty bad asthma. Their asthma is usually worse than people without nasal polyposis in terms of control of symptoms as well as exacerbations. And you can see here in this chart on the left, when we compare patients with asthma who have nasal polyps, which is that first column, with those who don't have nasal polyps, which is the second column, the polyp patients have a lower lung function, a lower FEV1. They have more eosinophils in their sputum and in their blood, and they tend to require higher doses of inhaled corticosteroids for their disease, and their asthma control score is not as good as compared to all of these things as compared with asthma patients who don't have polyps. And you can see on the right that the number of exacerbations seen in patients with nasal polyps really is elevated. Aspirin exacerbated respiratory disease, or the so-called NSAID exacerbated respiratory disease, is a triad of symptoms in which patients have asthma that tends to be pretty severe, they have nasal polyposis, and they have hypersensitivity to aspirin and NSAIDs, in that these things trigger respiratory symptoms and sometimes other systemic symptoms. So the asthma tends to be difficult to control. These patients have a lot of inflammation in their airway, as evidenced by increased mucus production. Their smooth muscles are more hypersensitive, more bronchoconstriction, and lots of symptoms, including wheezing. The sinusitis generally is a pansinusitis, and so these patients have quite significant disease. Their polyps have lots of eosinophils in them and also lots of chemicals like leukotriene. They also make extra mucus and tend to have quite symptomatic hyposmia or anosmia, so reduced sense of smell. And upon exposure to aspirin or other NSAIDs, even the topical forms, patients can have a significant worsening of their respiratory symptoms, including severe asthma, nasal obstruction, and sometimes what looks like anaphylaxis. So what's really fun, I think, about where science has been going lately is to try to understand really the mechanisms of what's happening underlying each of these disease processes. So for chronic rhinosinusitis, there are basically three major inflammatory endotypes, or characteristics of cells, cytokines, inflammatory cascades that are present in this disease. So the type 1 inflammation is really what you remember back from immunology courses as being this classically kind of anti-infection inflammation that's a normal response to infection. You have presence of macrophages, natural killer cells, cytotoxic T cells, as well as type 1 helper T cells and innate lymphoid cells. These cells function in a cytokine milieu that includes interferon gamma, so there's production of IgG antibodies, there's IL-12, and so there's stimulation of all of these different cells. And we think that this type of inflammation is characteristic of patients who have chronic rhinosinusitis without nasal polyps, and that this inflammation leads to that classic or characteristic purulent nasal discharge that these patients get, in addition to the filling of the sinuses and the sinus pain and pressure. The type 2 inflammation is what we think of as a type 2 or Th2 inflammatory milieu, in which you have alternatively activated macrophages, lots of eosinophils in the tissue, as well as basophils in the blood. Mast cells can be involved through local presence in the local tissue and activation through IgE antibodies. And then you have the type 2 innate and helper T cells. These things secrete IL-4, IL-5, IL-13, which are your characteristic type 2 cytokines. IL-5, as you might remember, recruits and activates eosinophils to tissue. IL-4 and IL-13 can help with class switching to IgE antibodies locally and systemic. And then IL-13 can also contribute to airway inflammation and mucus production. So these type 2 cytokines, when this is really present in the respiratory tract, we see this often in asthma, but we believe that this contributes substantially to the development and persistence of nasal polyps, as well as the symptoms related to the nasal polyps, like anosmia. You can see this type of inflammation in the non-polypoid disease as well, but it's more common in the polyp disease. And then finally, type 3 inflammation is something we don't think a lot about, but this is more on that IL-17 pathway where you have Th17 cells and type 3 innate lymphoid cells that release IL-17 that recruits neutrophils locally, and the neutrophils can participate in the inflammatory response. IL-22 can also be released from these Th17 cells and contribute to that inflammation, and this also contributes to the purulent nasal discharge that can be seen in both types of sinusitis. When we try to compare in generalities the differences between the non-polypoid sinusitis and sinusitis with polyps, generally the non-polyp patients have a more type 1 or Th1 milieu. They can have comorbidities of asthma and allergic rhinitis. It's just not as common as the polyp disease. Polyp disease tends to have more Th2 inflammation and more frequent comorbidities. We talked about the type 2 cytokines, and I think it's worth spending some more time on this because not only do we believe this contributes very substantially to nasal polyposis, but also these are targets for many of the biologic agents we'll be talking about in a few minutes. So we'll start on the left side of this slide. So where does this all begin, this whole process of developing sinusitis and nasal polyps? Well, we believe that the exposures from the environment, whether they're allergens, bacteria, viral particles, other irritants like smoke or particulates, can irritate or can stimulate the epithelial layer, so that kind of outer layer of our nasal tract. And that epithelium might be actually already abnormal because of colonization with bacteria like Staph aureus, because of biofilms that may be present from previous inflammation, from previous infections, an imbalance in normal microbiome, or maybe abnormal production of protective antimicrobial products. The epithelium essentially gets activated by these exposures and releases the chemicals that are called alarmins. This includes TSLP, which is thymic stromal lymphopoietin, interleukin 25, and interleukin 23. And these chemicals essentially activate and recruit the type 2 inflammation that we see through both adaptive pathways, which is the T helper cells, and through innate pathways, which is the innate lymphoid cells. So these cells themselves release cytokines and contribute to downstream activation. One of those important pathways is the development of allergy, which is shown on the top of the right side of this slide. So IL-4 contributes to B cell isotype switching, and so the B cells start to make antigen-specific IgE antibodies, which then can circulate all over the body and land on the surface of mast cells and basophils, and then they can subsequently be degranulated to release inflammatory mediators. B cells can also be activated by Staph aureus superantigen to make local IgE. The IL-5, like we talked about before, can recruit eosinophils to the site of the inflammation. The eosinophils can get into the tissues, can live for quite a long time, can themselves release type 2 cytokines in addition to lots of other mediators and toxins, and drive some of the local inflammation. And then finally, IL-13, the chemical itself is really interesting in that it can drive a lot of this epithelial inflammation through increasing mucus production and making more goblet cells in the epithelium, which are the cells that release and make mucus. Fibroblasts can also be activated to remodel the airway, and which might contribute to some of the fibrin deposition and the polyps growing, as well as increased collagen production. All of these pathways contribute to that abnormal inflammation of the upper airway and the development of nasal polyps. Okay, so we'll go back to our case study, which is Bob. And so we collected more information on Bob. He is, summarized a 45-year-old man who has worsening nasal polyps with comorbid asthma. He's had a couple of courses of oral corticosteroids and has used appropriate nasal saline irrigations and intranasal steroid sprays for a while. His lung function is reduced. He's he reverses properly, so that confirms his asthma. His exhaled nitric oxide level is greater than 25, which probably means there's some type 2 inflammation. And he denies any history of aspirin or NSAID exacerbated respiratory symptoms. Okay, we have all this information. He's definitely a polyp patient, and he seems like he's probably an uncontrolled or severe polyp patient based on his symptoms. So what are we going to recommend for him? What's our therapeutic options, and what should we be encouraging him to try? Are we going to send him for functional endoscopic sinus surgery? Are we thinking about biologics at this point? Are we recommending the exhaled delivery system with fluticasone, or would we consider putting him on alternate day oral corticosteroids? I can tell you I would not consider putting him on alternate day oral corticosteroids because we have such great other treatment options. So let's talk about some of those other options. All right, our medical management. I'm a medical doctor, so I like medicines and medical interventions, but I will say that I work very closely with a group of talented sinus surgeons who can provide that surgical management when it's appropriate. So what does standard of care medical management look like? So standard of care essentially is saline irrigations, which can come from something like a neti pot or can come from a large volume squirt bottle. These are saline solutions, not just plain water. And this is a large volume that's flushed up into the sinuses and comes out the other side, and is really meant to kind of get everywhere in there. We usually encourage our patients to do saline irrigations once or twice a day if they can tolerate it. Intranasal corticosteroids would be the nasal sprays that we know are widely available over the counter: fluticasone, triamcinolone, some of the others. And occasionally our patients are encouraged to use nasal drops into their nose instead. So instead of spraying it at the front of the nose, to actually drop it into their nose and let it percolate a bit. And then finally, oral corticosteroids in short term can provide acute relief for very significant symptoms. So while these interventions, at least the saline irrigation and the intranasal corticosteroids, are very, very safe, they're very inexpensive, but unfortunately they're associated with a high rate of failure, meaning that our patients often have persistent nasal polyp symptoms that are, or chronic sinusitis symptoms, I should say, that just simply don't improve enough or long-term. So we have other treatment options now that we can provide to our patients. This exhalation delivery system with fluticasone is an intranasal spray that gives fluticasone, which is that same steroid that we use in other sprays, but the delivery device actually allows it to get into all of the different areas within the nasopharynx and into the sinuses that are open. And I think you can see here that basically what happens is the little nozzle goes into your nose, and then the patient will blow into the tube. And so the force of their exhalation delivers the drug into the sinuses and kind of gets it in everywhere, whereas the regular nasal sprays stay mostly at the front of the inferior turbinate. The study that was the phase 3 trial, the Navigate-2, led to the approval of this treatment in 2017. This included patients who had moderate to severe CRS with nasal polyps, and polyps were eliminated in a quarter of these patients on at least one side by week 24, compared with 8% in placebo. They also had improvement in their symptom scores and a reduced need for surgery. Okay, so what do we do about surgery? Functional endoscopic sinus surgery is essentially a dramatic fix. It removes polyps, it removes the inflamed sinus tissue, and it essentially gets the patient back to their normal nasal function. So patients feel better right after nasal surgery. The success rate is up to 90%. And it's a relatively minimally invasive surgery. It does require anesthesia with intubation, but these patients heal in about a week. It's an outpatient surgery. They're out of work for a week, and then they're back, and they're doing pretty well, healing over time. And this goes in through the nose, and so there's no cuts on the external surface, and really endoscopically addresses the nasal polyps and can go into the sinuses, can open up the ostia, so not only is drainage more normal, but it allows for better delivery of medications topically. Cons are that, unfortunately, even though you're kind of cleaning out the sinuses, the nasal polyps can grow back, and it's estimated that about 40% of patients will have recurrence of nasal polyps in about 18 months after their surgery. And patients, in order to try to prevent or delay the recurrence of polyps, are encouraged to use things like intranasal corticosteroids or other intranasal steroid delivery devices to try to prevent that regrowth. We know that type 2 inflammation is a strong predictor of return of nasal polyps. So patients who have the eosinophilic disease, they have blood eosinophils or eosinophils in their polyp tissue, are more likely to have recurrence of the polyps. And of course, this is a surgery. And so even though our surgeons are amazing and highly specialized, complications can occur. The GALEN, the Global Allergy and Asthma European Network, kind of looked at this. Their patients received nasal irrigation, intranasal corticosteroids, and periodic short-term oral corticosteroid therapies. Despite this medical management, about 46% of patients with nasal polyps in this cohort required surgery to control the disease or to get better control of the disease. And in this cohort, the nasal polyps recurred in 20 to 35% of patients at 6 months and in 40% of patients at 18 months. Unfortunately, a third of patients required another surgery over the 12 years of follow-up, and 20% of patients require multiple surgeries over that time. So surgery by itself might not be the best option for long-term management. One really interesting and kind of cool intervention that our surgeons can consider for our patients is these steroid-eluting stents. These are stents that essentially have kind of mometasone or steroid impregnated in the stent that can be released over weeks within the tissue very locally to help prevent polyp regrowth and to help reduce the inflammation that's there. These are approved for adults who have undergone a previous sinus surgery. These stents can be placed in the office to locally provide relief of inflammation, and can be placed in the operating room at the time of surgery to try to help improve the healing after surgery. The Resolve 2 trial was the phase 3 study that looked at these stents, and patients did seem to do better with the stents placed locally and a reduction for revision surgery. Let's talk about the biologics. I think about biologics a lot. So the Euphoria group put together criteria that they recommend utilizing when you're considering initiating a biological therapy for patients with nasal polyps. So the first indication for nasal polyps should be that the nasal polyps are bilateral, which speaks to the severity of the disease perhaps, but also suggests that this is part of that normal nasal polyp related inflammation. If you have a unilateral nasal polyp, our ENT doctors are generally careful and concerned and will consider biopsy to make sure it's not a cancerous mass or some other form of nasal polyp that would be cured easily with a surgical resection. So bilateral nasal polyps are the inflammatory kind. If you have a patient who has had surgery that kind of counts as a previous intervention or criteria, then there's a list of criteria that the Euphoria guidelines encourage you to consider. So is there evidence of type 2 inflammation by blood eosinophils, by eosinophils in the tissue? Is there a need for systemic corticosteroids? So have patients required periodic intervention with steroids? Are they feeling bad? Is their quality of life impaired? Do they have a loss of sense of smell? Do they have comorbid asthma? So in a patient who hasn't had surgery, then you want to see at least 4 of these criteria present before you kind of go on to a biologic. If a patient's had surgery, then 3 is enough, and the surgery counts as one of the criteria. There are 3 biologics right now that are approved by the FDA for treatment of nasal polyposis, and there's another that's emerging, so it's in phase 3 trials, and we'll talk about each of these. Dupilumab is an anti-IL-4 receptor alpha antibody, so it blocks signaling of both IL-4 and IL-13. And this was the first to be approved for nasal polyposis in June of 2019. This is a medicine that's administered subcutaneously every 2 weeks at a dose of 300 milligrams. There were 2 phase 3 trials that were used to show the efficacy of this drug. Omalizumab is an anti-IgE antibody that many of us have been utilizing for a couple of decades to treat allergic asthma and chronic urticaria. This received approval in 2020, in December of 2020, as an add-on treatment for patients who still had polyps. Omalizumab, as you may know, is dosed based on serum IgE level and patient's weight. And there are dosing charts available online, or there are calculators and things. The dosing chart is a little bit different than the dosing chart for asthma. It goes to higher doses, but it's dosed every 2 or 4 weeks, and the phase 3 trials were polyp 1 and polyp 2. Mepolizumab is an anti-IL-5 antibody, so it binds up the IL-5, and so it's meant to reduce the eosinophil activation and recruitment. This was approved just recently in July of 2021 as add-on maintenance for adults with inadequate response to nasal steroids, and is dosed 100 milligrams subcutaneously every 4 weeks. And the Synapse study is their major phase 3 trial. Benralizumab is an anti-IL-5 receptor alpha chain antibody, so it blocks signaling of the IL-5. It's in a phase 3 trial to study efficacy for nasal polyposis, and this is administered subcutaneously as well, monthly. So we'll talk a little bit more about the first 3 because the last one doesn't have data published yet. All of these clinical trials, as you can imagine, require some very strict objective evaluation of nasal polyps and whether they're getting better. So one of the most important objective severity scoring systems that we use is this nasal polyp score that we previously mentioned. So the nasal polyp score is scored on each side of the nose and then added. And so the total score that you can have is 8, minimum is 0. 0 essentially means that with nasal endoscopy, there are no visible polyps. A nasal polyp score of 1 means that with a nasal endoscopy, you can see small polyps that are really limited to the middle meatus. So they're not reaching below the inferior border of the middle turbinate. So they're blocking just the part of the nasal cavity there. I think you can see this is meant to be the nasal turbinate and the inferior turbinate. Score 2 means that the polyps are below the border of the middle turbinate, but not quite to the inferior turbinate. Score 3 is that the polyps are much larger and they're actually extending to the bottom of the inferior turbinate, or they're extending medial to the middle turbinate. And then finally, polyp score 4 means that the polyps are completely obstructing the inferior nasal cavity and often can be seen without using any scope, just at the front of the nose. And over here at the bottom, you can see an example of the nasal polyp scoring, and these polyps each meet score 3 because they're reaching the inferior border of the inferior turbinate. In addition to that objective polyp size score, we really want to know how our patients are feeling. And so there are subjective symptom scores that are commonly used for patients to basically describe how well their symptoms are managed. The nasal congestion score is a really important patient evaluation of symptom severity that focuses on the congestion and obstruction. So it's kind of a surrogate marker for how big the polyps are and how well the patient's how well the patient can breathe. And so over 24 hours, the patient's asked to say whether they have any symptoms. No symptoms, a little bit of symptoms, moderate symptoms like I know they're there, but they're tolerable, or severe and they're impacting my daily living. So for these next few slides, you'll see the results from the clinical trials looking at both nasal polyp score change as well as the nasal congestion scoring change. So this is the data from dupilumab. And so there were 2 studies, the Sinus 24 and the Sinus 52, which were similar in the types of patients they recruited. The Sinus 24 administered therapy for 24 weeks and then watched patients when they came off of the drug. The Sinus 52 administered drug for 52 weeks. The placebo is in gray, and you can see compared with placebo are the orange and red lines at the bottom. So the top charts are the nasal polyp score. I think you can appreciate that for patients who are on therapy, the nasal polyp score improved by approximately 2 points over the first 3/4 of a year or a year of treatment. The nasal congestion scores also improved significantly for these patients. By about 6 months, you were seeing that they had dropped by 1.4 points from baseline. And I think you can also appreciate that when patients came off medication, that their symptoms did recur. Although maybe not yet to baseline at the time that they were finished with the monitoring period. The dupilumab studies also looked at the reduction in requirement for oral corticosteroid bursts or surgery. So essentially patients who are just, struggling despite the intervention and despite their regular medications and who needed something in addition. And you can see the placebo line here over the year of this study, 41% of patients needed either steroids or surgery to control their disease, whereas the patients who were on therapy, about 12% of them required intervention. And then finally, the safety, which is very important. It's nice to know that things are effective, but we also want to let our patients know that we're not going to harm them unnecessarily. So if you've ever participated in a clinical trial, you know that you're supposed to kind of report everything that happens to the patient, even if you don't know that it's related to the treatment. So you're comparing basically everything people are reporting in the placebo and the treatment groups. So you can see here that there were not an increased rate of the serious treatment emergent adverse events on dupilumab, or there were not frequent events leading to discontinuation. The most common events were nasopharyngitis, which I think we'll see for some of the other biologics as well, but no increased frequency of symptoms or side effects in the dupilumab group compared with the placebo groups. Moving on to omalizumab. So this is the results of the omalizumab Polyp 1 and Polyp 2 trials. And again, this is the change in nasal polyp score, and the gray represents the groups that received placebo, and the green shades represent the groups that received therapy. The primary efficacy analysis was at week 24 at the end, but there was a secondary efficacy analysis at week 16. And I think you can appreciate here that the mean change from baseline in nasal polyp score was about 1.25. For both studies. And so the patients, they did show benefit, and it looks like they, their symptoms improved within that first few months of therapy. And this is the nasal congestion score for the omalizumab groups. Again, patients had improvement in the nasal congestion scores at about 1.0 within the first few months of treatment. Omalizumab safety is reported here for Polyp 1 and Polyp 2 trials. You can hopefully appreciate that the number of treatment-related adverse events was maybe a little bit higher in the omalizumab group. Let's look at the most frequent events. We again see here that nasopharyngitis was pretty common. Patients who were on omalizumab reported less asthma exacerbation, which is maybe something we would expect because it will treat that as well. And a slight increase in injection site reactions in the treatment group when compared with the placebo. We can move on to mepolizumab, which is the anti-IL-5 antibody. So they're showing their data a little bit differently here. This is from the Synapse phase 3 trial. On the left is the nasal polyp score. And the way this is shown is on the top is the treatment group, and on the bottom are the placebo group. And this is showing you what proportion of those groups fits into each category. So which proportion got worse over the time of therapy, had no improvement or no change over the time of therapy, and then how many people had a 1-point improvement in polyp score, 2-point improvement in polyp score, 3-point improvement, 4-point improvement, or 5-point improvement. And so when you're comparing the red to the gray, you can see that maybe a few more people who were on placebo had worsening of their nasal polyps, although you did see worsening of nasal polyps in some people on treatment. You saw a similar pattern with no change. But then there's definitely more red in the people who improved. And you can see there's a small group of individuals, but a group nonetheless that seemed to have improvement in their nasal polyp scores. To 2 points, 3 points, 4 points. And then on the right, shown similarly, this is the change in the nasal obstruction by the visual analog score, so slightly different scoring system. And this is worsening in the nasal congestion score, really no change, and then improvement in the nasal congestion score. And while it looks kind of similar, I think you can appreciate that slightly more people who were on treatment had benefit. And it looks like people who had a lot of benefit were certainly different when they were on treatment. The Omalizumab trial also looked at a reduced need for surgery. So again, capturing information on those patients who were struggling so much that they ended up getting surgery during the treatment period. The probability of nasal surgery is shown here with a hazard ratio of 0.43 for patients who are on treatment. The Omalizumab safety is shown here. There didn't seem to be a strong signal for adverse events related to the intervention. But again, you can see that nasopharyngitis looks to be the most common adverse event, occurring in about 25% of patients who were taking either the drug or the placebo. Sinusitis and asthma were less common in patients who were getting treatment, and really nothing else stood out significantly for patients who are on therapy. So now that we know about the biologics and we know about the medical and surgical interventions, how do we pick something for our patients? And how do we sit down and tell somebody, this is what's going to make you feel better? So unfortunately, there aren't really great algorithms to doing this yet. And I say yet because I know that many of us are really committed to developing these sorts of recommendations. What we'd like to be able to do is say, okay, Bob, based on your measurements or based on your characteristics, I think this medication is going to help you, and it's going to help you 80%. We can't really do that yet, but we do have some recommendations about how to start selecting a biologic. So the first thing to do is to make sure the patient has the diagnosis of severe uncontrolled CRS with nasal polyps. It may be useful to look for comorbidities and consequences of those comorbidities, such as uncontrolled or severe asthma, because the comorbid diagnosis of asthma may help you select treatment based on what's indicated for different types of asthma. It's helpful to check that the type 2 inflammation is likely or present through blood eosinophils, maybe IgE levels, tissue biopsy if you have it, so that you know if you're addressing the type 2 inflammation through these biologics, it's potentially going to be helpful for the patient. It's really important, of course, to let the patient know what their different options are, because there's really not one thing that we know is going to be the best for any individual patient. We want to make sure that our patients who are making decisions about what to do are informed about the pros and cons and different characteristics of each of these different interventions. And when we select a biologic drug, we want, we want to feel that we've done the right thing for our patients, and that this is a really group decision, and it might be the best thing for the patient. When we do pick a biologic, we acknowledge, and as you could see from that data, not everybody gets better all the time, and there can be some variability in response to each of these different interventions. So please bring your patient back, reassess them, and make sure that they're doing well on this therapy. So what we'd like to see after about 6 months of treatment is that there's improvement in at least one symptom or at least one score that we can measure. So is the sense of smell getting better? Is the nasal congestion improving? Are the polyps shrinking? Is the SNOT-22 showing better symptom control? The visual analog scale of symptoms, is that getting better as well? If at 6 months the patient's not improving, I think most specialists and the Euphoria guidelines would say maybe that's not the right intervention for that patient. Maybe consider surgery to clear them out, maybe consider switching to another biologic medication. If the patient's seeing some benefit at that 6 months of treatment point, then the question becomes, okay, patient, you're improving in these different domains. Is that good enough for you? And if they say, sure, yeah, I think it's better, then maybe continue that biologic therapy, because you may see increased improvement or additional benefit over the subsequent months. If the patient says, it's not good enough, I'm not doing better enough, then it's a good time to consider other options, including maybe a short course of systemic steroids to reduce the inflammation and allow the biologic to maybe work a little bit better, do another surgery while they're on the biologic to see if the biologic might help prevent the polyps from growing back, which is not known yet, or switch to something different. After 12 months of therapy, if the patient's doing great, meaning that they have reduction in their nasal polyp scores, their nose is more open, so less congestion, visual analog scale of symptoms is not 22 or significantly improved, the patients aren't requiring surgery, they're not requiring steroids, then that's a really great response. The Euphoria guidelines set these kind of numbers as cutoffs for what's considered an adequate response. You might consider adding some of these scoring systems into your usual assessment of patients so that you can use them for determining whether somebody has adequately responded. And if somebody has, and they're not having significant side effects of the biologic, and the biologic is not too expensive for them, and they're able and willing to continue doing it, then I say continue with the biologic therapy. These are therapies that are kind of intended to be more long-term treatments and interventions. If the patient's not responded adequately, then you could consider at this point a different biologic drug or surgery. I think it's really important to consider what shared decision-making looks like when you're talking to patients. And it a little bit depends on what they've already tried and what you've already recommended. And I think most people would suggest or encourage using standard of care therapy to start with, of course. So the intranasal steroids, the saline irrigations. And if patients aren't doing well with that standard of care, then they have a few options. They have the Fluticasone breath powder exhalation device as a medical option. They have biologics as a medical option, and they have surgery as a surgical option. And so you can talk to your patients about these three things. If the patient's had a surgery and their polyps have grown back, then you want to talk more about what interventions might be useful then. Do they get another surgery? Do they get a surgery with or without a stent? Do they have a stent placed in the office? And do you consider a biologic at that point? If they failed multiple surgeries, then again, you're having those same discussions and talking a little bit more about what might be driving their disease and how to get it under better control. And then finally, if they have comorbid other diseases such as asthma or the other type 2 disorders that can be managed with a biologic, then maybe you talk more about the potential benefit of using a biologic to treat multiple diseases versus a surgical procedure to help control the disease. This slide shows kind of a summary of information your patients might need for that shared decision-making process. And this is adapted from the shared decision-making tools for CRS with nasal polyps that were developed by the American College of Allergy, Asthma, Immunology, and the American Rhinologic Society. And you can see the reference here. So essentially, you want to be able to describe to your patients, what the treatment is, what it entails to do it. Is this a surgery that you have to take time off work? Is this an injection that you're going to give yourself periodically? Is this something you're blowing into your nose? And you want to discuss some of the pros and cons of it, which may be whether it helps other comorbidities, whether it's something that you can that you can do at home. Cons being things like side effects, complications, potential for it to work or fail. And then the cost, of course, is a big thing and might be the limiting factor for some of these interventions with our patients. So when you sit down with your patient, please feel empowered and encouraged to talk about each of these different interventions and see what might be a good fit for your patient. So for our case study, this poor gentleman, Bob, with severe CRS with nasal polyps and asthma, we discussed this. We went through the whole shared decision-making process with him. He hadn't had surgery yet. He has comorbid asthma that's pretty significant and requiring high-dose asthma therapy. So we talked about the biologic therapies that are also approved for nasal polyps and asthma, listed here in order of FDA approval. And I think it's important to kind of talk about each of these different interventions. So you can talk to your patients about surgery, and he says, well, I'm not sure if I want to do surgery. I'm going to have to miss time from work. I'm scared of surgery. I don't know if that's the best thing for me. And then you end up talking about some of the other interventions, about the the potential benefit, the data of improvement for these different biologics, how they're dosed, how they're administered, and try to help him come to a conclusion that's going to be the right next step for him, remembering that we will bring him back in 6 months to reassess his symptoms if he's on a biologic, and maybe sooner than that if he's had surgery or other interventions. Okay, so in summary, CRS with nasal polyps is a highly prevalent disease. The nasal polyps accounts for 20% of all patients with chronic rhinosinusitis, which is 12% of our US population. Common comorbidities include asthma, allergies, and aspirin or NSAID exacerbated respiratory disease. It's generally driven by type 2 inflammation characterized by cytokines IL-4, IL-5, and IL-13. Medical management often is not adequate, but that's kind of standard of care. And so we can add additional therapies to try to improve that, including surgery, the exhale delivery system of Fluticasone and Biologics. The surgeries can be very successful, but can also be associated with high rates of nasal polyp recurrence, particularly in those patients who have type 2 inflammation. And there are 3 biologics now FDA approved for nasal polyps. And so we can talk to our patients about what each of those drugs do and figure out whether they might be the right decision or right treatment option for our patients based on the patient's goals, their dosing preference, and their insurance coverage. So with that, we can head to the post-test. And these will be the same questions that we answered earlier. And hopefully we feel very confident answering them now, seeing that we've gone over them in this last hour. So the primary cytokines involved in type 2 inflammation, which is the most common endotype in nasal polyps, are listed here. So I'm seeing most of you who have answered, everybody's answered 4, which is the IL-4, IL-13, and IL-5. So those are absolutely the type 2 inflammatory cytokines that contribute to those different allergic and eosinophilic and IL-13 pathways that we discussed. Wonderful. Next slide. Which biologics showed improvement in nasal polyp score by more than 2 points in close to half the population at weeks 24 and 52? So we did look at this. We looked at the relative improvement in nasal polyp scores in each of these groups. And it looks like all of you were captivated by the data because everybody who's answered the question has also answered dupilumab, which is correct. And the others, Omalizumab got to, I think, 1.25 after about 6 months. Next question. What is the most commonly observed treatment emergent adverse event for all of the biologics here? I think in the pretest, about 60% of people said injection site reactions. But it looks like here in the post-test, the majority of you are recognizing that it actually is nasopharyngitis. And because the rates of nasopharyngitis were similar in the treatment and placebo groups, it's unlikely that it was a side effect of the therapy and more that nasopharyngitis just happens in people who have rhinosinusitis. Oops, sorry, next one. Mr. Brown has sinusitis, he has surgery, he has type 2 inflammation. What does Euphoria recommend for, I guess, next steps for him after an intervention, after his polyps have grown back? And I can see most of you at the pretest said biologic drug or revision surgery. And you're right, and all of you are saying that now. That's what's recommended by Euphoria. Next slide. Last question. He's discouraged, and he's not sure that he wants to go through surgery again. So what does shared decision making tell us to do at this point? In the pretest, you all were split about half and half on the last 2 options, but it looks like now everybody's agreeing that you want to talk to him about all of the treatment options available and the pros and cons of each, and that really is going to allow him to help you make the decision about the best course of action. Wonderful. Well, great job on the post-test, everybody. So we have a couple of minutes for Q&A, and I'm just going to look over here in the question box and see if there's anything posted. I don't see anything posted right this second, but we'll keep an eye on that. Let's see here. There's one question that says, can nasal polyps alone cause snoring? And yes, I have seen that because when the nose is obstructed like that, at least partially, patients can have increased snoring. Patients with nasal polyps are at increased risk for sleep disorder breathing as well, like on the sleep apnea spectrum. And so improving their nasal polyps control might actually improve their quality of sleep and overall health. Another question, any tips for clinicians to help ensure the cost of a biologic is covered by the patient's insurance? This is a huge challenge, I think, for all of us. The different companies have patient assistance programs that can help to look into that for you when you're starting a biologic for them. And so we would encourage you to start using those programs. Our office has also been keeping track of the different providers and what their requirements and recommendations are. So we know that if we have a patient who's on Medicare, these are the steps we need to take. If we have a patient who's on a, TRICARE insurance, it's this. If they're on a commercial, it's this. If it's a Medicaid plan, it's this. So with experience, hopefully your office will get better and better at figuring out how to do it, but it is hard. And then finally, can a PCP diagnose nasal polyps on exam without referral to an ENT specialist? Thank you so much for that question. So yes, absolutely. For patients who have polyps that are large enough, so they're kind of coming closer to that middle turbinate or past the middle turbinate, you should be able to see them if you're skilled with the physical exam. So for this, I would encourage just looking in everybody's nose, even if you don't think they have nasal polyps, and so you can just get really good at the anatomy. And you absolutely can see the polyps that are in there. After patients have surgery, sometimes the polyps recur in their sinus cavities first, and you won't be able to see that on the anterior rhinoscopy, but certainly I would encourage you to look for them. Okay, thank you so much for joining us today. There are additional resources and information related to nasal polyps available on this website. For those of you who are looking for your CME credits, if you're kind of signed in through the system, you'll be redirected to that evaluation that you can claim your credits at, or you can go to this website